I'm Jeffrey Mitchell. I'm one of the surgeons here at Animal Surgical and Orthopedic Center. Joined the group in 2019, and actually used to work with with these guys back when I was a undergrad at UW, and then I went off to vet school at WSU, and then did a kind of rotating internship at Texas A&M, followed by a residency at UC Davis, and then I was working down in Southern California, and these guys called me up. Couldn't resist an opportunity to come back to the Pacific Northwest, so here I am. So to start, just going to say a brief thank you to some of our sponsors who kind of made this possible, and also making that Amazon gift card possible, which I'm sure all you will, or at least 50 of you will enjoy. So Zoetis, also want to thank American Reagent Animal Health, producers of Adequan, and also Nutramax, Dasquin and all that. Also, we do have one special sponsor. It looks like it's not. There we go. One of our special sponsors here is Doppler Band. So this is actually the brainchild of one of our own technicians, who we're all very proud of, to come up with this product and then even to kind of create a business around it. But Doppler Band is kind of a quick and easy way to secure the little Doppler crystal on a patient's paw. So if you're interested in that, feel free to kind of look it up online. You can go to dopplerband.com, where I believe you can even order them online. But yeah, very cool product. So we'll kind of get right into it. Kind of the format of today's CE is going to be, we're going to go through kind of multiple cases. We're going to describe about how maybe we would manage these cases. I'm trying to concentrate more on subjects that we get a fair amount of emails about, just consults kind of throughout the day, and maybe go through some of our thinking about, why we make the recommendations we do, or why do we say, we should splint or cast for this amount of time. So we'll kind of get into that as we go through all the cases. If we have time, we do have a cool kind of angular limb deformity case we may go over, but only if there's time. So for this first case here, this one is Bambi. It's a 3-year-old female spayed Chihuahua. Fell out of the owner's arms and was acutely non-weight bearing on the right front limb. This was a case I saw back in my residency back at Davis. And so these are the initial radiographs taken by the referring vet. You can see here, we have a kind of a short oblique, very, very distal radius ulna fracture with some, mild displacements. Now, the kicker for this case is that this happened 6 months prior. So by the time they actually came and saw us, the dog had been cast for pretty much 6 months. And they came to us because the bone had not healed yet. So we'll talk a little bit about why that's probably the case in these kind of Chihuahuas and toy breed dogs and all that. But yes, so it came to us, did have that non-union of that distal radius ulna, along with a pretty significant kind of valgus deformity as well. So just to kind of go through a quick little question here, you kind of just think about it in your head. There's no poll that you necessarily have to fill out here, but if you had to think about it, why did this not heal? Was it due to overactivity and maybe the initial veterinarian wasn't able to get things reduced enough? Was it because just splinting and casting of the limb is just not stable enough to allow for bone healing for these toy breed dogs and the radius ulna fractures? Would you say that the radius ulna fracture is too oblique to cast in the toy breed dog? And maybe if it was more transverse, they would have had better luck. Or, you win some, you lose some. It should have healed, but for whatever reason, it didn't. And I don't know what happened, So just take a second, I guess, think about that. I mean, hopefully it should be a pretty straightforward answer. But we'll kind of get more into that here in a sec. Okay, so hopefully you said option B. So in these toy breed dogs with radius ulna fractures, they just do not have the greatest healing potential. So they need very rigid stability in order to really ensure, or give them the best chances that the bone is going to heal. Option A is not the best answer just because overactivity and, saying that the fracture wasn't reduced enough. Maybe that can come into play in some types of radius ulnar fractures, but in a toy breed dog, it's not something you necessarily want to blame on that. That could be a contributing factor, but probably not the whole story. The idea that the radius ulnar fracture is too oblique, and maybe if it was more transverse, it would have been okay. Also, probably not the best answer because there's just some more physiologic reasons why it's not healing. And then the whole win some, you lose some, that was kind of just a throwaway answer there. So to kind of get into why is it that toy breed dogs have to be treated differently for these radius ulnar fractures? You know, one thing would be just the overall size of their radius tends to be a little bit small for their body size, and they can fracture from pretty minimal trauma. Typically, they tend to be kind of a transverse to short oblique. You know, they tend to happen in the distal third of the antebrachium, kind of the junction between the metaphyseal and diaphyseal bone there, because there's just that sudden change of the diameter of the bone. So it's kind of a weak point there. The small medullary cavity that we see in toy breed dogs is definitely special to them, where they have, like if you look at these images here, they have a pretty pinpoint medullary cavity compared to their cortical bone. And then if you look at the medium and the larger breed dogs, they definitely have a lot more medullary cavity. And so that's going to translate to a better interosseous blood supply, which if you think about bone healing, which we will kind of get into more, bone healing really relies on good blood supply. So for toy breed dog, they just don't have the best blood supply. They don't have a whole lot of soft tissue coverage over their bones along their forearm. So their blood supply is going to be compromised to begin with. So you need to optimize everything else about this fracture healing in order to try and give you the best chances of a good outcome. And then also even the bone quality and the metaphyseal blood supply in the actual bone itself has been shown to be kind of inferior for these toy breed dogs. So, you know, if we look at this image here, the black is the vasculature along the metaphyseal bone. And then this is a more larger breed dog. You can see the network of vasculature is much more intensive. So they just have a better blood supply, which is going to translate to better bone quality, better bone healing. So when we think about these radius ulnar fractures, you know, something that can be useful to kind of throw out to your owners would be, you know, if you're presented with a radius ulnar fracture in a toy breed dog, you can kind of tell them if this is not surgically stabilized, there's about an 83% chance, you know, based on the literature, that that bone is not really going to heal. So that's obviously a big deal. And even with surgery, because of the kind of shortcomings that we just talked about, their potential for healing is still going to be a bit decreased. So even with surgery, we appreciate maybe a 12.5% non-union based on the literature. I would say that's a bit high from what we typically see because, you know, I would say we kind of know what the problems are and we try and fix that with the surgery. But if you look at the literature, it's about 12.5 versus all other kind of fractures out there that are reported non-unions is closer to 3.4. So definitely those radius ulnar fractures in toy breed dogs are tricky. But surgery is the best option. I wanted to show you this case for Bambi because this is a situation where, you know, it was casted for 6 months. It was definitely a non-union, but there still are options. It's definitely not the easiest thing to repair at that point because what we ended up having to do for Bambi was went in, we debrided all the fibrous tissue. We had to use pins to kind of open back up the medullary cavity to try and reestablish blood flow. We put on this plate and tried to get, you know, as much bone sharing the load, as much compression as possible, packed it with bone graft. Ended up having to splint still just because if you look here, the bone plate is not the biggest. So ended up still having a good outcome where you can see, you know, that's the fracture immediately post-op, and then the fracture is healed at around 8 weeks post-op, and you know we've stopped splinting, increased activity slowly over time. But yeah, this was definitely a tricky one, and these toy breed dogs also have some other kind of interesting things about them where when you fix these fractures, if you splint them for too long, or even if you have the implant is too rigid or too big, you can actually see their bone just melt away. So that's just some of the things that we consider as one of the reasons why for Bambi here, she has has a kind of a wimpy plate just to try and avoid those kind of complications. So overall, a good outcome, but still a long road to get there. All right, so any questions? And again, you can use the Q&A section if you have questions, and we'll kind of have these pauses throughout the CE just to kind of go over anything that seems like a relevant, good question to go through. So let's see. Izzy's going to be kind of helping me figure out where to go. Looks like we don't have any questions, so we might just one in the chat.
Mm-hmm. How long does it take to fully heal?
I'm guessing, are we talking about the Bambi case? Because that was about 8 weeks to bone healing. And really with that, like we had enough bone healing that we could at least take out the splint and all that kind of stuff. And then I typically will do like a slow return to function and activity over about another 4 to 6 weeks. So looked at around 3 months of total activity restrictions on that one. Anything else? Okay, all right, we'll move on to the next. Okay, so this kind of brings up the question, do all radius ulnar fractures really need surgery? So this is kind of a complex question and answer, but in general, there's just many factors to think about with this. And, again, this is a very common kind of emails and questions we get from you all is sending us images and radiographs and kind of getting our input on, is this something they should be sent over to a surgeon, or is this something we can just splint? So, we'll definitely go through how we think about it, but at the end of the day, you have access to us if you want to email us images or questions, and hopefully we've been pretty good about getting back to you pretty quickly. So feel free to keep on doing that. We do enjoy looking at those and even kind of discussing amongst ourselves. So keep on sending them our way. So for the many factors we think about, like, breed and size, like we kind of just went over some of the big reasons why that's a big thing to consider. But now let's think about things like the type of fracture, the displacement of the fracture. So for transverse fractures or fractures where there's some interdigitation that you see there, or ones that are really minimally displaced, if we feel like we can provide some stability there or kind of maintain somewhat sort of stability, then potentially splint management and casting, all that kind of stuff can make more sense. In terms of getting the fractures reduced by greater than 50%, like that's a common number that gets thrown out in the textbook. So 50% is good, greater than 50 is better. But at the same time, if you get 50% reduction, is it going to stay reduced as that dog or cat or whatever starts walking around on that leg, the next couple of days? So it also has to be something that can be sustained and it's not going to slip and kind of, lose its reduction. So that's another important thing to think about. For radius ulna fractures, if the ulna is intact, that's a big bonus. The ulna is kind of like an internal splint. It will kind of prevent the radius from hopefully collapsing further, even if there is a slightly unstable fracture. If there's a transverse fracture, having the ulna intact is a huge help there. So you definitely splinting and casting and all that kind of stuff starts making more sense for those kind of cases. I also look at patient age, and we'll kind of get more into that down the road, but patient age is a good kind of correlation to overall healing of these fractures. And, how long are we going to have to maintain the bandage? Because, patient temperament may play a role in that. Like, how crazy are they? If they're really crazy, is it something where I don't think I can maintain that bandage for that long in order to get the bone actually healed? Or is it something where, the patient temperament will tell me that, we're actually have to splint for a lot longer because they're going to be so active, they're going to delay their own healing? Or even, are the owners going to be able to keep their dogs quiet enough, keep those bandages nice and clean and dry? So those are just some other things I usually think about. And then, ultimately also owner finances play a role. As much as we would love to just be able to do what's best for the patient, no matter what, and like we have to consider what can the owners afford. So, I mean, if surgery is just not on the table, you can consider splinting a fair amount of these fractures, and you can get away with, quite a bit sometimes and get lucky. But, you have to kind of understand the fracture biomechanics and how, I guess, the shortcomings of splinting and casting, all that kind of stuff. And, maybe if it's one of those things where the medical management is just unlikely to get things healed for the fracture, do you have that conversation kind of earlier on about the potential for, amputation? If they can't afford the surgery with the repair, could they maybe afford an amputation? Or maybe sometimes I know some of the general practitioners do amputations, and I'm sure if they can do that, it'd probably be cheaper with you all. So, I mean, you can definitely talk about the options. It's probably good to talk about that up front before they've done several weeks or maybe a few months of splint management and all that kind of stuff. But again, feel free to send us emails with images or any of that kind of stuff. We're happy to look at them for you. So we'll just kind of go through a couple examples and kind of just think about, as we go along, like what you would recommend, what you would do if you came across this case in the real world. So these are the radiographs for a 7-month-old male neutered husky. So you can see here, there's a long oblique fracture of the radius, pretty minimally displaced, and the ulna is intact. Okay. So I would start looking at this and start thinking about like, what are the pros and cons for bone healing? And that'll help me make a decision, like how likely is this going to be healing through the different little options we have. So the pros would be that it's 7 months old, so he should probably heal pretty quickly. The ulna is intact, so that definitely does provide some extra stability. And then it is fairly minimally displaced, mostly due to the fact that ulna is there and kind of holding things where they are. So, that's definitely helpful. The cons for this would probably be that it is a long oblique fracture. So, those oblique fractures like that, there's a lot more shearing forces between the fracture ends there. Shearing forces, like bone healing doesn't tend to love shearing forces. But in the right amount of stability, it can still go on and heal. The other downside to long oblique fractures is that there's not really a whole lot of bone sharing the load there. So you don't necessarily, like you have a little bit more instability there compared to say like a transverse fracture. And, even though I went to UW and I hate to be Breedist, but it's a husky. So, you can probably assume that probably going to be pretty energetic. So you'd have to be a little bit cautious about that. And so if we're thinking about, what would I do in this situation or what could you do in this situation, you start thinking, would I splint this or would I refer this for surgery? I would say honestly, you can kind of go either way in this case. Conservative management definitely makes sense. You have some things that are really going for you that are positive. So conservative management, very reasonable. I would probably, if I was doing this case, I'd probably splint it for around 6 to 8 weeks or so, and then transition to a soft padded, and then maybe recheck radiographs at around 6 weeks post-injury, and then still keep the dog fairly confined for about 2 to 3 months overall. Now, let's say if the owner, finances is not an issue, you're worried that it's a husky, so maintaining a bandage for a long period of time is going to be very difficult. Or the owners just, they say like they don't want to be coming back and forth with bandage changes all the time. They want something to kind of just get taken care of right away. Surgery, very reasonable option. If they want to go that route, it'd be a fairly easy procedure. Just slap on a bone plate and some screws. It'd be very stable. Probably wouldn't even really necessarily splint that as long as the repair came out well. Probably just do a soft padded bandage maybe for about 5 to 7 days for compression. Still recheck radiographs at around 6 weeks post-op. And then, for the confinement, it's important to, I guess, understand, like, even with surgery, we're probably going to keep the dog confined for about 2 to 3 months as well. So the confinement is going to be fairly similar in terms of how long we're keeping them confined, because again, we're basing this all on bone healing. So bone healing kind of happens, as long as you give it what it needs, it happens in a pretty predictable timeline. So 2 to 3 months of activity restrictions. Now, the benefits of surgery would be, since we don't have a bandage in place, because we have the plate on there keeping the radius stable, we would probably start giving this dog more leash walks initially. And so we would have progressively longer and longer leash walks during that recovery process. So that's a benefit there. And also, since we're not using a bandage, probably less chance for bandage sores and disease and all that kind of stuff. So surgery has its benefits for sure. So here's another one. So this is an 8-week-old male castrated pug. So here you can see there's kind of a short oblique to transverse radius ulna fracture. It's really not displaced at all. Again, pros and cons. Very young dog, should heal very quickly. They're short oblique to transverse, so that's definitely going to have some bone sharing the load. So that's nice. Non-displaced, and potentially in these really young puppies, what you can see is their periosteum is very thick in puppies. And so there's a possibility the periosteum is still intact in this case. And it's impossible to say that based on radiographs, but that's definitely a positive when it comes to when you're trying to manage these conservatively. So yeah, I'd say a no-brainer. I think there's a very good case to consider conservative management on. But what if it was displaced? If it was displaced, and significantly so, I probably would say push towards surgery. Not to say that you couldn't try and sedate or anesthetize a dog, get the fracture pieces reduced again, and then splint it. And because it's such a young dog, it probably could go on and heal pretty well. But yeah, maybe the surgery route sounds more appealing if there is displacement of the fractures. So let's say if we were doing conservative management, how long would I splint it and all that? So splinting, I'd say 10 to 14 days as a general rule for something like this, but probably closer towards the 10-day mark, honestly, just because that's going to heal so quickly. And we'll talk more about bandage disease a little bit later on, but I'm trying to get these puppies out of bandages as quickly as I can. So yeah, about 10 days, maybe a splinting, transition to a soft padded bandage, and then maybe recheck radiographs at around that 3-week mark, when they're taken out of the bandages anyways. After the recheck radiographs, probably still keep confined for maybe another 2 to 3 weeks afterwards, really depending on the healing there, just to make sure everything solidifies before they're running around and being too crazy. So here is just kind of our warning page about do not splint for too long. I'm sure a lot of a lot of bad things can happen with splinting, and especially if you push it too long and splint for too long. So obviously bandage sores, I'm sure everyone has some story, or if someone's heard some story about, taking a bandage off and toes falling off and stuff like that. But with bandage sores, they just complicate things, definitely increase risk for little infections and stuff like that. So you can kind of manage bandage sores with plenty of donuts, plenty of padding. If you know that you're going to be bandaging a leg for a while, it's probably better that you start being aggressive about extra padding and bandages or donuts kind of earlier rather than later, putting bandaging material in between the digits and dew claws, all that kind of stuff, just to try and ward off those bandage sores as much as you can. The other thing that we see very commonly when a joint has been immobilized for several weeks is that actually the cartilage itself can degenerate over time. So the cartilage, it's one of those things where it relies on nutrition from the joint fluid kind of being moved around and all that kind of stuff. If it's locked in one position, it's not getting all the nutrition it needs. And so it starts to degenerate. It probably takes a couple of weeks for it to really start happening. And it probably takes several weeks for it to really become potentially more permanent damage to the cartilage. But one thing you'll see a lot of times, even if you've been splinting for a couple of weeks, is once you take out of that splint, their wrist or their ankle is very sore and uncomfortable. So I kind of expect that. I warn owners about that. I typically will transition to a soft padded bandage after splinting for a couple of weeks, just to kind of give them a little bit of a transition and a little bit of compression for comfort. You probably want to send home some additional maybe pain meds when you take out a splint. But it's one more reason not to keep them splinted for 2 months, 3 months. Without good reason to do so. The other things that we see with young animals, definitely, especially like the puppies and kittens and stuff like that, is if you splint the leg, they can actually have the ligaments of the carpus and the kind of tarsus actually get more lax, and so you start seeing a lot more kind of instability or hyperextension of those distal joints there. In kind of young dogs or toy breed dogs, you can also see this osteopenia that starts developing. So here's an actual example. This is like an 8-month-old Chihuahua. I saw about 6 weeks after splinting for, it was like a very, I think it was a Salter-Harris distal radius ulnar fracture, which actually got away with from splinting. I think the owners had no finances to really pay for the surgery right away. They spent the time doing the medical management, and the actual regular vet was able to get the fracture reduced really pretty nicely, and things healed up pretty nicely just from that. So got lucky there. But yeah, ultimately at 6 weeks when they came to see us for potentially, surgery at that point, we took off the splints, and we took these radiographs which show, pretty significant osteopenia along the distal radius, along the carpal bones there. The overall alignment was pretty good. The carpus did have some pretty significant hyperextension there. So that kind of laxity there will hopefully just get better as they start weight bearing again. But it is something where you need to get them out of the splint. So, transitioning to a soft padded bandage or something like that for a little while, and then getting them out of the splint so they're weight bearing. The other thing that we see very commonly with splinting too long, like maybe more in the elbows or the stifles, or sometimes in kind of older dogs, is you start seeing a loss of range of motion, which will kind of improve a little bit as they loosen up again, but sometimes it can be a little bit, it kind of sticks around a little bit longer. Here's another example of some laxity in the joint. So this is a case I saw where it was about an 8-week-old male intact pit bull, had a distal tibial saltaris 2 fracture, which I cross-pinned. And just to kind of give you an idea how quickly that laxity can set up, this was one where I just splinted for about 2 weeks, and then we switched to a soft padded bandage for about 5 weeks. So here are the post-op x-rays at 3 weeks post. The fracture is healed, the pins are stable. So this is when we took out of the soft padded bandage. You can see that the tarsus is pretty much buckled forward. And when I palpate that tarsus, there's some mild medial lateral instability. So taking out of the bandage and splints and all that kind of stuff, letting the dog weight bear, that improved and the dog did just fine. But, if you keep the dog splinted for a lot longer, you may not see that fully return back to normal. Let's see, we may have some questions here. I guess we should probably peek through. Let's see, from Kathy, do you recommend meds and crating for confinement? Definitely. I guess it depends on the patient a little bit. Probably meds would be a good idea, especially if you have a rambunctious animal. Crating, I think, depends on how well they can keep them confined. Like, if you have a dog that can be penned maybe, or, some owners will even just kind of have a couple pens throughout the house. They kind of move them here and there to kind of stick around with them so the pets can kind of see them and hang out with them. That if you can keep them from running and jumping and playing, and you can prevent them from developing Baines disease, then I'd say that's probably fine to do. Let's see. From Samuel, does the fact that the dog is castrated at such a young age have any influence on the decision here, or if the injury was different? So probably, the overall healing of the bone, there's a lot of probably more important factors than whether or not they have that hormone influence or not. So I probably wouldn't say that's a big influence, at least for me, when I'm thinking about these fractures. Let's see, do you ever recommend cold laser therapy for cases like this with no displacement? So I'm guessing we're talking about that one pug with the non-displaced radius ulna fracture. I guess I don't typically recommend it all the time, because I'm not also recommending a lot of rehab therapy for a case like that. Like, it'll be healed. Like, luckily those little puppies are healing machines, so it's going to heal kind of on its own. You can always consider cold laser therapy. Maybe if you're trying to do that for an older patient, you may consider doing that to try and speed up the healing process for them, because otherwise they're going to take a little bit longer anyways. Let's see. What imaging would show whether the periosteum is in place? Probably, if you did things like an MRI or something like that. But oftentimes, like if you're looking at that soft tissue detail, I guess you could maybe do an ultrasound too. But honestly, the periosteum is a big benefit, but that's not probably something that would make or break whether I would do conservative management or not on that one. But yeah, it is definitely a soft tissue structure, so you're not going to really pick that up on radiographs or even CT. You need something to actually look at the soft tissues. And then last one, what do you recommend for bone kind of fractures and for pain management? I would say probably NSAIDs are one of the most beneficial kind of pain meds you'll have. So I definitely say layer it around NSAIDs, and then you can add on top of some other pain medications in addition to that. Gabapentin, a very common one that we use here. It's something where it may help for the pain. It also provides a little sedation, which is useful. The things like, codeine is becoming more popular in the area recently, and we have that, and that's kind of what we use as well. I feel like the codeine, the opioid type medications are a little bit better for the acute kind of the pain that you'll see after a more traumatic event like that. So I do like codeine for that kind of stuff. Tramadol, debatable, how well that really works. I'm sure a lot of you've heard that a lot of people are talking moving away from tramadol, just because the concern would be that the way that tramadol is broken down in our veterinary patients is not the same way it's broken down in the human medicine. And so it's just, not metabolized to the point where it's as effective. So I don't tend to use a lot of tramadol. You can also consider things like we also use some amantadine from time to time. I'd say I like that a little bit more for kind of chronic pain management and stuff, but sometimes I'll throw amantadine in even for my post-op patients too, depending on their size and what formulations we have and stuff like that. So hopefully that answers those. Okay. Okay. So now we'll go to our second case. So this is Copper. Copper's a 5-year-old male castrated boxer Doberman cross, was hit by a car and was non-weight bearing on the right front limb. On examination was painful, there was crepitation, and there was a small laceration over the right metacarpal region. And these are the radiographs. So here we have a kind of a transverse fracture, kind of distal diaphyseal of metacarpals 3 and 4. You can see a little bit of subcutaneous emphysema right there. So, it kind of corresponds to the idea that there's a small little laceration there. And there is some soft tissue swelling around the area. So we'll take this time, like we get a lot of emails about kind of these metabone fractures, whether the metacarpals or metatarsals. So just to kind of go through what are some of our guidelines on how we recommend surgery or not surgery. These are the general rules that we think about for recommending surgery. It's a bit extrapolated from the human side of things. So you have to take it with a little grain of salt, and there will be exceptions to these rules from time to time. So again, feel free to email us. We're happy to look at your radiographs. But if you have more than or equal to 3 metabone fractures, with that amount of fractures, you probably should start considering surgery, or at least that it makes more sense to start considering surgery. If both of the primary weight-bearing bones are fractured, so 3 and 4 are fractured, probably surgery makes the most sense. If you have fractures that are pretty displaced, and you can't get them reduced, and you're meeting the other criteria that we talked about in the first 2 there, then probably surgery makes the most sense. The other thing that you can think of, and maybe less intuitive, is like if you have fractures of the bases of metabones 2 and 5. So pretty much, here and here, you actually have some of the ligaments attached in those areas. So if you have a fracture and you have displacement of those fracture pieces, you may have instability of that kind of distal carpal or distal tarsal joint. And you may need to repair that in order to restore stability to that joint. So, you can determine that based on palpation, whether or not you do get a little bit of extra medial lateral instability. Stressed radiographs can be very useful. I definitely would encourage you all to do stress radiographs at your practices. It doesn't really take a whole lot, just some additional shots and using maybe a wooden spoon to kind of push the paw around a little bit. So pretty simple to do and gives you a lot of information. And then articular fractures. Articular fractures are the one that are a little bit harder to say for sure all the time. If it's a simple articular fracture, something that has a decent enough piece of bone that we can kind of put a pin across or put a screw across to basically stabilize, then yeah, articular fractures probably should be repaired. Now, that being said, I'd say the majority of the articular fractures we end up seeing are ones that are pretty bad, or there's just not enough bone to really put back together again. Or if you could get the bone back together again and get reduction of the actual joint surface, is it going to sustain or maintain that reduction as that dog starts walking on that leg, a couple days later? Even with a splint, it's still, taking a bit more of the stress there. So again, articular fractures in the human side, they'd probably be much more aggressive about fixing all those, because we can have patients offloading that leg completely or that arm, like they are not walking around on their hands and stuff. So that definitely makes maybe that a little bit more realistic. The other thing that we think about with dogs is that, if they do have an articular fracture, sometimes, yeah, they'll have some arthritis in that joint once they heal up, but overall, is it going to affect their quality of life or their kind of gait that much? Maybe not. And they may do just fine without a true surgery of that. Now, if we're going in anyways, because we have to repair a couple of the other metabone fractures, like we may go in and try and repair that articular fracture too. But, if they can maybe get along with a little bit of arthritis and be okay, we might just leave it alone. The other consideration would be if they do have really severe arthritis in that joint down the road, I guess we have the option for a digit amputation in the future, and probably that dog would do pretty well with that too. So just some things that, we think about when we're looking at these, and you can kind of do the same. The other thing that we kind of think about is like, when we're recovering these patients and doing the kind of post-op recovery, the implants we're using for them is pretty small. Like even for big dogs, if we're able to use those plates and screws, like they're going to be pretty small plates and screws. So even after the surgery, we're having them in casts or splints. Most of the other repairs that we do, like with pins, those are mainly there to kind of maintain reduction and alignment and all that kind of stuff. We kind of consider the splint or the cast as like the main stability or the main kind of protection for those fractures as they heal. So definitely that's one of those things where we splint after surgeries, pretty much regardless of what surgeries we do. And in general, we get to take them out of the splints and bandages a little bit sooner than we would if we just did conservative management, but not always. It kind of depends on a lot of factors, like how bad the fractures were, how long, can we maintain that bandage without the dog developing a bunch of sores all over the place. So, we kind of have to take it with a grain of salt too. All right, so kind of back to Copper's case. So we have a couple options here to kind of think about and see what you would do in this scenario based on the guidelines we just talked about. So would you A, refer for surgery since the fractures will not heal with splinting alone? Would you B, say it's not a surgical case since 3 or more metacarpals are not fractured? C, would you say it's not a surgical case since there is a wound over the fractures and a high risk for infection with the implants? Or D, say refer for surgery since the main weight-bearing metacarpal bones are fractured? Okay, so probably the best answer would be just refer for surgery because the metacarpals 3 and 4, which are the primary weight-bearing digits, are fractured here. Technically, A is not correct because probably these bones will heal. It may take a while unless you can really get the reduction to be pretty good. But they're the main weight-bearing digits. Is a big dog. It'll take a while to heal. It may have a malunion to them. Ultimately, would that be a huge, I guess, detriment to Copper? Probably not. He's like not playing the piano or anything like that, so he'd probably be fine with that. But it may not be his best option. B is not correct because the first rule that we talked about was 3 or greater metacarpals, but when it's the primary weight-bearing digits, it's kind of its own different kind of setup there. And then saying it's a non-surgical case since there's a wound over the fractures and it's a high risk for infection with the implants and all that. It's technically true that there will be a slightly higher risk for infection. But when it comes to the implants, we have a couple different options for dog Copper size. Like we potentially, if there wasn't a wound, we probably would consider plates and screws. But if there are wounds, we're probably just going to use pins, which is pretty much what was done. So if you use these pins, the way we have to place them in there, it's coming out at the very top parts of that kind of metacarpal phalangeal joint. So we end up removing the pins regardless, no matter what, like whether there's infection or non-infection, those pins are coming out anyways. So having that wound over that site doesn't affect us too much. One caveat to that would be if it was a really bad wound or maybe a degloving wound or something like that, that might affect whether or not we do surgery right away or not. Because, we may give the soft tissues more time to declare themselves. We may say like, oh, if the wound is that bad that we have to maybe consider amputation of the limb, or sometimes it's one of those things where, the entire soft tissue is completely debrided away and we're worried about overall fracture healing altogether. So we'll see how the wound progresses over time and then maybe consider, doing some kind of repair if we got to that point, but maybe not. So yeah, here are the post-op images. We fixed metacarpals 3 and 4. Casts and bandaging was done for this dog. And then I believe this one was taken some recheck radiographs around 10 weeks post-op with kind of splint management the entire time with bandage changes every 1 to 2 weeks. You can see here the implants are still nice and stable within the shaft of the metacarpal. You see some really nice smooth bridging callus on either side. So I would consider this fracture pretty much completely healed. There's going to be some more remodeling that's going to happen here. But the pins were removed, transition taken out of that bandage, and a slow return to activity over about another 4 to 6 weeks after this. Technically speaking, 10 weeks, a little bit longer than when we typically would recheck most radiographs after this kind of fracture, probably 8 weeks. I'm not sure if this case in particular, maybe it was, the owners couldn't show up at the 8-week mark, or they forgot, but either way, this probably would have been good enough to remove those pins about 2 weeks prior, but overall still healed and a good outcome there. So these next 2 slides we're going to go over, sorry. These next 2 slides we're going to go over is kind of just a general breakdown of how I think about how long to splint these metabone fractures. And the next slide will be kind of about when to recheck radiographs and what to evaluate for those radiographs. Because those are definitely very common questions we get along with those radiographs you send in is, how long do I need to splint this for and how should I do it? So for me, and this is mainly for metabone fractures, you can kind of extrapolate a little bit to other distal limb fractures, but primarily we're talking metabone fractures here, but the timeline for splinting is gonna be variable and dependent on a lot of factors. But I kind of start off with almost a baseline time point where I think about what is the age of the patient, what's the healing potential of the patient, and kind of adjust things from there. So if I look at the age of the patient and I kind of break it up into a couple different groups. So pediatric patients, I'd probably consider, any patients, puppies and kittens, less than about 3 to 4 months, probably. Like their healing potential is going to be pretty rapid. Younger juveniles, probably in that maybe 5 to 7, 8 months of age or so, like still pretty good healing potential, but maybe not quite as good as a puppy. And then your older, kind of adults and your older juveniles is like 9 months and up, So I think about how quickly I expect them to heal in kind of an ideal setting with, reasonable stability of these fractures. And so I start there. So for pediatrics, like maybe 1 to 3 weeks, probably closer to the 1 to 2 week mark, honestly. Like 3 weeks would have to be pretty bad fractures for it to take that long to really get them out of a splint. But 1 to 2 for pediatrics, young juveniles 3 to 6 weeks, and then adults, closer to 10, older juveniles closer to 6 to 8, is what I would think of. And then you start kind of working down the list saying, what type of fracture is it? How many of the metabones are fractured? If you think about those, every metabone that's still left intact is like an internal splint for that foot. So you can start thinking I can take them out a little bit on the shorter end of that period. If the fractures are pretty simple, usually simple fractures mean less trauma versus more high impact, high trauma fractures are going to be more comminuted or things like that. So generally speaking, the more the blood supply is disturbed, maybe the longer it takes for that blood supply to be reestablished and the longer it may take for the overall healing. Looking at the displacement, how displaced are the fractures? Do they have some good apposition? That's going to influence as well, like how quickly is this really going to heal? Looking at the underlying health issues, probably one of the big things I look at is, how healthy is the soft tissues around the metacarpal metatarsal region? Is there a big wound over that area? Is the blood supply compromised because there's a big infection as well? Those kind of things. But also even things like, is the patient a diabetic or is it Cushingoid or something like that? Those all could affect potential healing of those tissues. So other things that kind of keep in mind. the ability to restrict these animals. If you can keep a dog fairly restricted, you can they're pretty chill dogs in general. The less strain they're putting on those bones, usually the faster it can start healing. The more they're jumping around, being crazy, the more they're putting strain across those fracture gaps, and the kind of this more delayed and longer it could take to heal, because it requires more callus formation around those fractures to provide enough stability that you'll actually see mineralized bone being produced. Because mineralized bone requires, anywhere between 2 to 10% strain if you're talking about secondary bone healing. So it needs to be a certain strain level between those fracture edges for the bone to actually produce mineralized bone. And then from there, I check up on the healing that we can see on the recheck radiographs. I'll palpate these kind of fractured areas, looking for like how much callus can I feel in that area. It's not always going to be how much mineralized callus can I feel, but also just what kind of fibrous callus can I feel in that area, because that's going to provide a lot of stability. And then the radiographs we'll talk about here in the next slide, but you can kind of look at the signs for that secondary bone healing. And then also bandage disease, that plays a role in how long I keep these patients splinted for. It's one of those things where if the dog is really hyper and kind of crazy, it's a catch-22 where I want to maybe splint them a little bit longer because I need them to hopefully get more healing done. Because once I take them out of the splint, I know that they're going to test out that fracture pretty quickly. Versus also if they're very active, they're probably more likely to have bandage disease. So again, that goes back to the idea of assuming that they're going to have bandage disease when I first start the whole process. And I'm putting a lot more padding on them. I'm putting a lot more donuts on them. I'm preparing for the worst in those kind of cases. Or maybe I'm going to be changing out the bandages more frequently rather than letting them ride for 2 weeks. Maybe I'm changing them out every 7 to 10 days or so. So those are just the things that I kind of think about when I work through these kind of cases. So for this slide, we're talking about secondary bone healing. Anytime we're talking about getting a fracture to heal by casting or splinting, we're talking about secondary bone healing. Primary bone healing is only going to be seen when you actually repair a fracture. You can get no gap between the fracture edges. You have a very stable implant. So we're pretty much talking about secondary or indirect bone healing here. So with indirect bone healing, just to kind of go back to some of the basics, this relies on a couple of things. Like first, you need adequate blood supply, you need adequate stability, and you do need the fracture edges to be somewhat close to each other, But what you see is this callus formation over time. The callus formation increases the overall stability of the bone. And then the actual kind of fibrocartilaginous intermediate that is produced, if there's enough kind of control of the strain in between the bone fragments, it'll actually lead to mineralized bone formation. So that's how you kind of get that bone healing. It goes through that intermediate stage versus in primary bone healing, it goes straight to bone healing. It's just straight bone going across the fracture gap. So if we're thinking about, again, when to recheck radiographs for a lot of these metabone fractures, and again, you can kind of extrapolate this timeline to other types of fractures out there. But yeah, for pediatrics, again, those puppies and kittens less than about 3 to 4 months old, probably recheck radiographs around 3 weeks or so is a reasonable first step, and then kind of going from there. For our young juveniles, probably closer around 6 weeks through the recheck radiographs. For the adult and older juveniles, probably closer to around 8 weeks. Now, if you look at the timeline for the radiographs, you can see that it kind of correlates to when we're kind of finishing up the splinting and all that kind of stuff. So we're going to do the splinting, recheck radiographs at an appropriate time, repalpate, evaluate how much healing we have on the radiographs, and kind of go from there. So for these images here, this is actually an experimental model where they're showing a progression of secondary bone healing over a timeline. Honestly, it's a very good representation of it, but honestly, they did not have the actual exact dates in the paper. So I kind of would say, I would estimate that if this was done right after the procedure, this is probably around 4 weeks, post-op, and this is maybe closer to around 8 to 10 weeks kind of post-op. So if we look at the actual fracture gap here, it's very crisp here. it starts becoming a little bit more mottled here, and you do start seeing that callus formation here. So even though this is the mineralized callus here, there's still actually a fair amount of fibrocartilage and fibrous tissue creating more of the soft callus around here. And then here at 8 to 10 weeks, we're seeing actually a fair amount of mineralized callus filling in those kind of sides there. Now, if it's, you can still see the opening of the fracture here, but this is actually fairly stable at this point. So for example, if I saw this when I was rechecking x-rays for a metacarpal fracture at, 8 weeks, post injury, and, everything else was looking good. Like I palpated, it felt stable. It was non-painful. The dog seemed overall like, it's getting around really well. I would probably take out the splint at this point, even though we don't have complete fusion of the bone. It's like, this is going to be strong enough that we can probably take them out of that. Now, let's say if the dog was a crazy dog, it's jumping around all over the place, owners, are not going to be reliable at keeping them quiet. Then as long as the dog didn't have much bandage disease, maybe I might keep the splint on for another 2 weeks just for a little extra stability or a little extra, help me sleep at night. But you may not really need that for a normal dog. That's enough healing that I would be pretty happy with that. And so that kind of gets to the point of differentiating between radiographic healing and clinical union. So you can kind of assume on radiographic healing is going to kind of lag behind the actual clinical union and the stability that's there. So as long as you see and evaluate the radiographs closely, and you can see that there's this nice progression of callus, the bone edges seem less distinct, you can kind of assume that that has reached clinical union here. Now, if you were to splint until this reached full radiographic union where it's completely fused, you'd probably be splinting it for another month or so, which maybe opens up the patient for more bandage disease and stuff like that. So kind of just knowing at what point are things stable enough that I can go ahead and take them out of the splint is just an important thing to develop when it comes to splinting these kind of cases. So I think we have some questions we'll go through. So it looks like we have a question about codeine. So they read that codeine has very poor bioavailability. What's your experience with it? I would say the codeine, I think it does work. It's not the best opioid by any means. Of the opioids we have available, like if I had to choose between tramadol or codeine, I would probably choose codeine any day of the week. But yeah, I agree. It's maybe not the best, which is why it's not my primary pain medication. Again, I stick to the NSAIDs. That's probably going to be your best bet. And then having the gabapentin and the codeine or the amantadine, all that kind of be a secondary thing or a tertiary thing. That's the way I would probably go about that. Okay, and then let's see, another question is, how much activity should be allowed during restriction? So for restricting them, if we're talking about, really if it's medical management with a cast and splint and all that kind of stuff, I typically kind of keep it to maybe 5 to 10 minutes, maybe twice a day, in addition to their leash walks for bathroom breaks. I keep it very minimal when there's a bandage in place, because I'm trying to limit how much bandage disease they're going to develop, try and limit, how much, if they're constantly walking around and they're getting it dirty or wet or something like that. Like I'm just trying to make that bandage last as long as I can and kind of maintain their skin and all that as long as I can. So if they have a bandage on, 5 to 10 minutes maybe. If they're crazy, then I still are going to use more medications to try and keep them to that 5 to 10 minutes. If we're talking about after surgery, it kind of depends a little bit. There are some surgeries like the TPLO procedure, or let's say a radius-ulnar fracture where it's a very simple fracture around the kind of mid-diaphyseal. We get good compression. We have a good size implant screws on there, and very happy with the repair. Probably those kind of cases, I'll start allowing 5 to 10 minute leash walks twice a day at around 3 weeks post-op. And then I'll gradually build it up from there, where I'll add about 5 minutes every week. So, by the time they come back and recheck radiographs with us at 6 to 8 weeks, they could be doing like 20, 30 minute leash walks twice a day in addition to bathroom breaks. Now that's in a very secure, stable fracture repair. And we're still avoiding running, jumping, playing, all that kind of stuff. If we're talking about like a metacarpal fracture where we just have some pins in the bone there. If we're splinting for maybe 4 to 6 weeks or so, I'm keeping them to that 5 to 10 minutes for the most part. And then once we take them out of the splints, they're still going to be doing like maybe 5, 10, maybe go up to 15 to 20 minutes, but it's not going to be quite as extensive as some of those other fractures. So it just depends on the type of fracture that we're dealing with. So hopefully that answers that question. Let's see, how much more time are we allowed to talk?
Yeah, 5.
Okay. So let's see, we could go through this one. So this is this is Apollo, a 9-month-old male castrated Malamute. So he jumped down from a very high ledge on the owner's property and was non-weight bearing on the right front limb. There was pretty significant crepitation and pain associated with the right metacarpal region. The dog is a very active dog, normally has a lot of anchorage to run around on. There is one single radiograph taken at the time of the initial presentation. You can see there's some mild to moderate displacement of the kind of metacarpal fractures 2 through 5. There's no true wounds or anything like that, and no other injuries that were reported. So, based on what we've talked about before, what would you do? Hopefully it's a pretty straightforward one, but for A, you'd say it's a young dog and overall displacement's, not too bad. So possibly a good candidate for splint management. Would you say B, I would splint for 3 to 4 weeks and then recheck radiographs and refer for surgery if it's not looking any better? Would you do C, use a caudal spoon splint and refer for surgery? Or D, I'm going to make a fancy, nice little lateral custom fiberglass splint and refer for surgery? So I guess you can think about what you would do in that situation. Okay, so for this one, the correct answer would just be a caudal spoon splint and refer for surgery. You have fractures of metacarpals, 2 through 5, like that's an obvious surgical candidate there, especially it's a large dog, it's an active dog. Splinting that for a long period of time is going to be horrible or just no fun at all. So A's wrong, for that reason. B is incorrect because you can, splint it for 3 to 4 weeks and recheck radiographs. First of all, it's probably not a great splint management case to begin with, but splinting it for 3 to 4 weeks and then rechecking radiographs doesn't make a whole lot of sense in terms of overall, how we expect bony healing to progress. 3 to 4 weeks is not nearly enough time to really see much of a change along those fracture edges. And, if you recheck the radiographs at that point, you're not going to see any significant healing of the fracture. So it's almost like not really worth doing it because it's just, more finances for the owner, all that kind of stuff. But also, let's say if you don't see it healed at 3 to 4 weeks, which you wouldn't, is the scare going to be to say like, oh, we should go to surgery now because it's not healing appropriately? Now, if you have that idea, doing a fracture for a 3 to 4 week old metacarpal fracture or metatarsal fracture, really a lot of fractures, is pretty horrible. Like there's definitely going to be a lot of scar tissue around those fractures. Getting things reduced back to where they should be is going to be extremely difficult. And you actually end up having to do a lot more dissection, which is, again, affecting blood supply and all that kind of stuff, which could affect the bone healing down the road. So, if you were to send a fracture like that, that's like 4 weeks out or something like that, unless there's a fair amount of instability still there, we may not actually recommend surgery at that point. We may recommend just continuing doing the splinting. So just some idea that, if we wait that long, maybe we're not going to recommend surgery anymore. So it just depends. And then a lateral, custom fiberglass splint, not going to be the best option just because a lateral splint is not going to, really immobilize or kind of offload the pressure on those digits that well. So this is kind of the route they went. They did end up splinting and then rechecking radiographs at 3 weeks post-injury. You can see a little bit of mothing kind of areas of some of the bone where basically just remodeling of the bone. It's kind of in that reabsorption phase right now. You can definitely see on the orthogonal views here, they do have a lot more displacements than you could initially appreciate. And even here, you can see that it looks like kind of metacarpal 4 is trying to, find its way over to metacarpal 5 here. And metacarpal 5 is kind of just going up and behind the actual foot. So not great reduction by any means. But, at this point, they're splinting, continued splinting. So here's recheck radiographs at 7 weeks post-injury. So now, they've done the radiographs and they see, everything still looks like it's not fully fused across, which again, from, bone healing, the fact that these were not well opposed, the fact that it's a big active dog, the fact that it's, fairly displaced, all that kind of stuff, I wouldn't expect it to be healed at 7 weeks anyways. So this is by no means a surprise, but what you do see if you look closely is you can actually see there is some pretty decent signs of healing happening. So if we talk about what we saw when they came in for their consultation with us, one of the surgeons who saw this case was palpated the limb after taking the splint off, and actually the metacarpals were pretty rock solid. They were not moving anywhere. If we really zoom in on the radiographs here, you can see that there definitely is some bridging callus happening here. You do have kind of that bridging coming across here. There's more fibrous callus all around this whole area here. So you have more kind of evidence of kind of more radiographic union, or you're at least getting closer to that. And at that point, this, I think by the time we saw this dog, it was about 8 weeks out. So it was already starting to have some bandage disease and all those kind of classic things that you see for long-term splinting. So after palpation, after radiographs, and kind of knowing what to expect with that secondary bone healing, they were actually taken out of the splint altogether, because it sounds like the owners were having trouble keeping the dog, keeping the bandages clean and dry anyway. So it's potentially more risk if you just leave them on. So took out, kept restricted for another 4 to 6 weeks of pretty strict activity restrictions, and then gradual increase in activity from there. But, the dog did just fine. So this is just another case where just kind of knowing what to expect from the bone healing is a huge help for deciding when to take out of the splints or when to start increasing activity and all that kind of stuff. So yeah, kind of the learning points we kind of went through real quick was the early surgical intervention, definitely better for fractures, and definitely for metabone fractures. Like the sooner we kind of get in there, probably the better if they are going to go the surgical route. Thinking about secondary bone healing, timing for the rechecks, and knowing that initially there will be a reabsorption phase, so don't be too kind of worried about that. And then just the big difference between radiographic versus clinical union, and kind of knowing that radiographic union is going to lag behind clinical union. So it's an important thing to know. So let's see, it looks like we have a question. So by waiting for surgery, will the dog suffer long-term issues? So probably in terms of long-term issues, the biggest things would be maybe not being able to get the fractures fully reduced as much as we would like. So maybe ending up with more of a non-union is a potential. When we have to go in for a chronic fracture that's been sitting there for a couple of weeks, we have to dissect a lot more off of the bones. Like we actually have to disturb the soft tissues a lot more in order to actually kind of get the fracture ends back together again, versus like initially, before they have all that scar tissue, before they have all that contraction of the muscles, we can actually get these things reduced without too much, brute force. Versus if you wait down the road, it's a lot more of a struggle. And the more soft tissue you have to dissect off the bones, the less blood supply, the slower the healing, all those kind of things. So potentially longer the bandaging. So, long story short, I guess, in terms of long-term effects, maybe not, we may not be able to get the metacarpals or metatarsals or really any fractures as well reduced as we might like. So that may affect the patient long-term, but if we can get things reduced well enough and still get them to heal, then we should hopefully be in okay shape. Let's see, got a couple more questions. Yeah, so this dog never had surgery but healed in the end anyways, correct? That is correct, yep. You can get these to heal. Not the best way to heal it. Probably would have looked a lot prettier had they had surgery. And this dog got kind of lucky that they're able to get it to heal. So again, if the owner has no finances for surgery, I guess it's not something you naturally have to be all doom and gloom about. Still can get it to heal. It just may take a bit longer and be a bit more of a hard road for some of these big active dogs. Case 3, are those bones crossed? Yes, I think we're talking about the metacarpal 4 and 5 are basically crisscrossed. Yeah. So again, not the greatest healing there. So the question is, another question is waiting for surgery or failing to get a reduction likely to increase chances of early onset arthritis? So I would imagine that if you have your metacarpals kind of crossed like that, it's going to lead to some abnormal weight bearing in those joints, which could very well lead to some arthritis in that joint. If you can get the reduction to be pretty good and fairly close to anatomic, even if it's not perfect, you're probably not going to see a whole lot of problems with arthritis. Like you may see some minor stuff, but probably nothing too significant that I guess I'd be too worried about. But it's just very much going to be fracture dependent, I guess. I think that's all the questions. So let's see, I have one more case or two more cases. One's just a tibia tuberosity case, and then we have a cool angular limb deformity case. If it's okay with you all, I might just go through the angular limb deformity case because it's kind of cool. So this will be our last one. We'll get through it real quick. I might brush over some areas, but this is Ozzy, an 8-month-old male intact Bernese mountain dog, was referred to us for a front limb kind of deformity, more on the left side than the right side. The owners actually didn't really report much of a lameness issue, no real pain. They said that recently they noticed that the left wrist seemed to be progressively turning out, and it was kind of happening pretty quickly in the last month or two. So on physical exam, Ozzy there had a pretty severe left carpal valgus deformity with a pretty moderate torsional defect. You know, the left wrist was probably turned out maybe about 30 degrees, 35 degrees or so. So, you know, not great. Had some mild right carpal valgus deformity, but it was much more normal. I don't have some good pictures of that initial visit, but we will have some follow-up pictures to kind of go through. So on physical exam, there's also no real carpal pain, fairly well muscled, not really a big lameness or anything like that on the lameness or gait analysis, and pretty normal elbow range of motion with no significant pain on flexion or extension or any of that. So here are our radiographs. So this is, initial presentation, 8 months of age. We can still see there are some growth plates open in the right radius in the ulna. We can see a little bit of a mild carpal valgus of the right, a much more significant carpal valgus of the left. And then if we look here, we can see the distal ulnar growth plate is actually closed down. So it actually, we have a premature closure of the distal ulnar growth plate. The radial growth plate still is open, and it looks a little bit abnormal compared to the right side, but it still has some growth potential there. And then the other thing to notice would be, we do have not really much arthritis in the elbows overall, but there is a little bit of increased sclerosis along the ulnar trochlear notch there. So based on seeing that, I would say, the dog had a premature closure of the distal ulnar growth plate, has a pretty moderate to severe kind of distal forelimb valgus deformity with external rotation. The radial growth plate is still open, and we probably have some underlying, elbow dysplasia, most likely medial coronoid disease, but you can't rule out an OCD lesion or maybe some incongruity of the elbow, which, Bernese are very well known for. So kind of the options we discussed with the owners would be, we kind of have two major routes to go. One would be we do a distal ulnar ostectomy in order to try and release the pressure on the radial growth. And so hopefully it's not going to keep on binding up the radial growth. And it's mainly there not necessarily to correct the radial deformity. It's not necessarily going to do that. But hopefully it's going to prevent it from getting worse, because the dog's only 8 months of age. It still has some growth potential that's going to happen. So we're just trying to get that wrist from not turning out further or from having further external rotation. So that was the main goal there. And then we would still need to do a definitive correction of the radius down the road once Ozzy was fully mature. The alternative would be we leave things alone, we let Ozzy grow up, and once he's skeletally mature, consider doing one big corrective surgery all at one time. Now, during that time while he's growing up, his deformity is going to get worse for sure. And at the pace it was going, I was pretty concerned that it was going to be really bad by the time we got to 1 year of age, or 13, 14 months of age. So, if we got to that stage where it was that bad, probably doing the correction, like the simple correction where we make a cut in the bone and rotate it and put on the bone plane screws, is no longer to be an option. We'd probably be looking at having to do an external skeletal fixator in order to truly make that correction, because you have to do it slowly. Otherwise, if you have too much of a correction to make, you're not going to be able to make it all at one time, because all the soft tissues, muscles, and skin and all that will bind you up, so you can't do it. So we ended up doing the distal ulnar ostectomy. So here are the post-op images. We pretty much did it right away. We're trying to get that radial growth to happen without having the negative effects of having that intact ulna there. So that's the purpose for the distal ulnar ostectomy for this case. We also do the distal ulnar ostectomy for cases of elbow incongruency. Typically, that's going to be most beneficial in very young dogs. So in patients, probably less than about 6 months would be ideal, but potentially up to 8 months, we can see a little bit of movement where if we make that distal cut here, it actually will allow a little bit of movement of the actual ulna up here. So maybe if there is a little bit of elbow incongruity or that medial coronoid disease, which we always are concerned about with these kind of cases, that could potentially shift it enough that improves the overall conformation of the elbow. 8 months, that's towards the tail end of how effective that can be, because right around 6 to 8 months is when the interosseous ligament between the radius and the ulna starts to solidify. So that's a concern that maybe it won't do that much, but ultimately the angular limb deformity is the main reason why we were doing it anyway. So it was more of a bonus if it worked that way. And luckily, the distal ulnar ostectomy is a very safe procedure. It has very low chance for complications. So, if possible, if we're dealing with an elbow incongruity case or angular limb deformity case, we like to see them early so we can hopefully just do this and gives them a pretty easy surgery and has some pretty big benefits for them potentially. And so I want to say, definitely this was a huge help that the referring vet sent this to us when they did, and they didn't just kind of wait and see how the limb progressed. I think they noticed that the limb was having that valgus deformity, and they sent Ozzy our way. Whereas if they waited, this whole distal ulnar ostectomy would not have been an option, and potentially the limb would have been much worse off by the time we saw it. So, definitely kudos to them. So yeah, this is the recheck radiographs at 6 weeks post-op the distal ulnar ostectomy. So this is kind of pretty close to what Ozzy's paw looked like before the surgery. So really things have not changed too much in those 6 weeks. So it's kind of, we've had some success with the distal ulnar ostectomy in terms of the curvature in the deformity did not get a whole lot worse. It didn't get better, but I don't expect it to get better. But as long as it doesn't get worse, I'm pretty happy with that. We see that, again, secondary bone healing, we got some callus formation. This will go on and heal given more time. But I'm going to start increasing Ozzy's activity, let him start doing more and more. And the instructions we had were to come back and see us when Ozzy was about a year of age. I think because Ozzy was doing pretty well, no real complaints from the owners, they felt he was pretty comfortable. He didn't come back for about another year. So he was kind of in the wind for about a year. When he came back, the owners were kind of getting concerned that he's still not really limping much. He doesn't seem that painful, but they felt like his carpal valgus and external rotation was maybe a little bit worse. So, looking at him and kind of feeling him, I'd probably say his overall radial deformity and ulnar deformity had not changed a whole lot, but probably he had a little bit more medial carpal laxity just because the way his conformation was, it puts more strain on that medial collateral ligament. So that's why I just allowed it to kind of start stretching out a little bit. When I evaluated him, he did have some mild to moderate left front limb lameness, but overall, like his deformity had not changed a ton from where he was before. But at this point, I think they were more motivated to go and get moving forward with actual corrective osteotomy and all that. So we had him come in for the actual workup. Here we did a bilateral forelimb CT. So we can kind of plan based on the CT. We have 3D models that we can print. We can plan, what type of correction we need to make. So typically we think about these corrections in 3 planes. So we can we really outline that based on the CT. This is a nice little kind of representation, little 3D model of this is the left front limb. So you can actually see the curvature and then the external rotation of the leg there. I'd probably say the external rotation probably is around 45 degrees or so. And there's pretty severe distal radius ulna valgus and all that. And then if you look, there's also a fair amount of procurvatum, which means it kind of arches kind of up and down as you go down the radius in the ulna. So we got to do a little trial run with our 3D printed model so I can kind of figure out how much to remove and all that. But then, we did do the CT through the elbow, so we were able to diagnose that he did have bilateral medial coronoid disease, and he actually had fragmentation on the left side. So if we look at the transverse image of the left elbow, we can see a little fragment there along the tip of the medial coronoid. The medial coronoid's right here. This is actually the radial head here, and this is the humeral condyle started to come into view. On the sagittal view, we have the humerus here, so that's humeral condyle. This is the very tip of the medial coronoid here, and then that's the actual fragment. And then we have part of the radius kind of coming in the background there too. So yeah, we came up with a plan that we're going to go ahead and do the kind of left elbow scope at the same time as we do the corrective radial osteotomy. So here is the kind of planning image that we had. So we're able to kind of template out how much bone we needed to remove. So I measured out that we're removing about a 13 millimeter wedge of bone. This is called a closing wedge osteotomy, where we actually measure out how much of the bone to take. We take out a wedge there. And then when we put the radial fragments, kind of radial bone segments back together again, it straightens out the whole limb there. In order to get that to move, though, we do have to make another cut in the ulna in order to allow that to freely move over. So this is the kind of radiographs post-op. Overall, I was happy with the repair. Honestly, if I could have gotten a little bit more correction for the external rotation, it would have been nice. But because of the amount of rotation he had to start with, I could only rotate it so much before it kind of got bound up, and then it just wouldn't really go anywhere else. So I corrected it as much as I could, and overall, I was pretty happy with the repair. So post-op, we did end up putting on a caudal splint and bandage for about 4 weeks post-op, with changes every 1 to 2 weeks. And then we rechecked radiographs at around 10 weeks post-op. I think I wanted them to come in at 8 weeks, but they came in at 10 weeks instead, just because it was better for their schedule. So here's kind of their kind of image. This was before surgery. This is at around before we went down the whole route of doing the CT and the planning for the surgery and all that. You can see there's quite a bit of that kind of turn there and the external rotation. Here we are 10 weeks post-op. Ozzy was doing very well, walking very well on the limb. He maybe had a little bit of an intermittent mild limp, but whether that's from the wrist, whether that's from the elbow, that kind of stuff, but overall doing very well. And you can see his limb is much straighter, closer to what his right limb looks like. Again, if I could have gotten a little bit more internal rotation, I would have been a little bit happier, but overall a successful outcome. So Ozzy's doing well at this point. So let's see, it looks like we have a couple questions, and that'll probably be it. For Ozzy, how is the distal ulnar osteotomy or ostectomy managed post-op? So for those, I typically will maybe splint them for about maybe 2 to 3 weeks. The splinting there is mainly just for a little extra comfort. It's not necessarily because really the radius is the main weight-bearing bone for the most part of the forearm. So I kind of have a splint on for a little bit of compression, but a little bit of comfort for the first 2 to 3 weeks. And then typically I'll have them back at around that point. I'll palpate along the distal ulnar ostectomy site. If it feels pretty comfortable, if they're walking around pretty well, I'll typically take them out of that splint and just transition to a soft padded bandage for like a 5-7 day period. We did keep him restricted to just kind of short leashed walks and 5 to 10 minute leash walks, that kind of stuff for the first 6 weeks. And then once we saw the recheck radiographs at 6 weeks, Then we started slowly kind of increasing activity and gradually returned to more normal activity in about like another 6 weeks after that. Let's see, do you have any guidelines for when to refer chondrodystrophic dogs, especially basset hounds, for these kinds of repairs? Hard to know what level of angularity requires treatment. So yeah, this is definitely a good question. It almost seems like basset hounds having that distal kind of forelimb valgus deformity and external rotation is almost kind of breed standard. And honestly, we don't fix a whole lot of basset hounds, to be honest. Like, I'm not sure if it's something where they're just not that active anyways, and they're not necessarily getting around to the point where a lot of owners are worried about they're not doing well on their front limbs. So it kind of depends on the owner a little bit, I guess. If the owners are, very gung-ho about wanting to try and fix that, and they think that it's necessarily causing an issue for them, then probably, getting referred over to us for at least evaluation and talking about the overall workup would probably be reasonable to do. But the next question is overall, what was the cost to the clients? So this was probably, if I had to break it down, like the distal ulnar ostectomy, that was probably closer around like maybe 3,500 to maybe 4,000 or so. The recheck radiographs we tend to do is probably around 250 each. And then for the CT, the kind of planning that was done and the actual scope and the surgery, we're probably talking about maybe about $8,000 to $10,000. So it's definitely not for everybody. If finances are not a concern at all, then definitely there are some good outcomes to be had. But it's not cheap, unfortunately. And this is one of those cases where there's not a good way to necessarily shortcut things or cut costs in certain areas. In order to actually do a good job, you kind of need to do the full workup. And there are a couple stages that need to be thought of throughout this process. Okay, let's see, any other, I think that was the last question. And I think we're over time, or we're about out of time. So again, thank you very much for kind of coming in, spending your lunch hour and a half with us today. Hopefully this was informative. And again, we do really enjoy seeing your emails about different fractures and your questions about how to manage them. So definitely feel free to keep on sending them our way. We're lucky in that we have 5 surgeons that are all sitting in the room together, so we can always bounce ideas off each other. Even some of the images you send us, we kind of show them around the room and kind of get everyone's thoughts. So feel free to keep on sending them our way. We're happy to look at them, and we definitely appreciate all the referrals and all that. And if you have further kind of, requests or things like that you'd like for CE, I believe they'll kind of have some kind of questions for that you can kind of just list some topics that you'd be interested in, and potentially next CE, we can start filling through those as well. All right, well, thank you again. Well, take care. Have a good rest of your day.